Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. Welcome to the NCLEX Review. The first thing we're going to discuss is a safe environment. This is a fundamental of nursing practice. So part of this is understanding different types of precautions. So the first type of precaution we're going to talk about is the standard precaution. This is the precaution that we take for all patients. We use gloves for all bodily fluids. We hand wash between clients. We wear goggles for care that creates splashes or bodily fluids. Wear a gown if soiling our clothes is likely. Use needleless devices or safety needles when possible. And discard sharps in a sharps container. And clean spills of blood with bleach. So these standard precautions, we use these for everybody. This is to protect ourselves and other patients. We always don't know what patients have as far as like bloodborne pathogens and things. So we always just want to protect ourselves. So the next one we're going to discuss is droplet. This is a step up and it tells you what it is. So droplet, we're worried about droplets. So bodily coughing, those droplets that carry different types of bacteria. So the types of bacteria that we can remember for this is Dr. M. Phipps. And on NCLEX, you really don't need to have all of these memorized, but you definitely will want to know the airborne ones. But for the purpose of this, it's your rubella, your diphtheria, measles, mumps, Phipps disease, influenza, pertussis. Influenza is a big one. They might ask you about that, what type of precautions you need for influenza or pneumonia, because those are things that are really common. And we want to remember that droplet, we're wearing gloves, gown, face mask, and eye shield. Again, because we're worried about those droplets getting in our face, getting in our eyes, and then also we always wear gloves. That's our standard precautions. So that is our droplet. And if we move from droplet, the next one is contact. And contact is when we are worried about different organisms like Mr. Sui. So multi-drug resistant organisms, respiratory infection, skin infection, wound infection, things like C. diff. And we have to remember that C. diff is actually contact plus precautions. And what that means is that we wash with soap and water after we leave a patient's room with C. diff. We can't just use hand sanitizer. And then also eye infections. So for contact, we want to remember to give the patient a private room. We want to wear gloves, a gown, and again, using soap and water when we leave the room if it's a C. diff patient. And the private room is important because these multi-drug resistant organisms and skin infections, wound infections, we can pass from one patient to the next. So we really don't want to do that. So we want to make sure these patients have private rooms. The next one is airborne precautions. And the big one with airborne is the N95. That's what you need to remember. These airborne particles are much smaller than the droplet particles. So we have our droplet and our airborne are really tiny. So they can actually go between a face mask, and the airborne particles can get between a face mask and get through to us, which is why we need an N95. It's a certain type of filter that can filter out those airborne pathogens. And what we want to remember for airborne is our measles, TB, varicella, zoster, and SARS. Also, our COVID-19, very important. So we also want to remember neutropenic precautions. So our neutropenic precautions, these are used for immunocompromised patients. Typically, this will be chemotherapy, high-dose steroids, things like that. So we're always doing our hand hygiene. We're screening visitors from illness because we know they're immunocompromised. They could potentially get an illness that could be deadly to them because they're immunocompromised. They should be in a private room if possible, and avoid sources of possible infection. So big one, raw fruits and vegetables, flowers and plants. So if you have a question on NCLEX that asks you, a patient's family member comes in with flowers and they're on neutropenic precautions, what do? You don't allow those flowers in the room because they do carry organisms that can cause different infections. We also should remember that patients with a suspected infection should not be in the same room as an immunocompromised patient or a patient with wounds, again, because we can contaminate and spread those diseases and bacteria and viruses to other patients. Fall precautions. So when a patient is on fall precautions, they've been identified with some type of screening tool that they are at risk for falls. And we know that falls are a very big deal because they can lead to some serious adverse outcomes for patients. And that's why it's one of the things that the government monitors inside of hospitals and facilities is the number of falls. So what we want to do is orient our patients to their surroundings. We want to make sure to be assessing that client frequently, making sure they don't need anything if they're on fall precautions and we don't go see them for 4 hours and they're trying to get out of bed because they need to use the bathroom and they fall. That is not good. Usually you could implement something like 1 hour rounding where you come around every hour just to check on them, but need checking. Keeping personal items within reach. We don't want them reaching outside of the bed to the table where they could fall. Teach them how to use the call bell. Make sure they can reach the call bell. Keep the bed in the lowest position and raise 3 of the 4 side rails. The reason it's not 4 of 4 is because that is actually technically a restraint. So we have to do 3 of 4 side rails. We want to keep the floor dry, free of cords, and free of clutter because we know all of these things can cause people to fall. We want to make sure they have slip-resistant footwear on. If they're wearing socks, they should have the kinds that have the rubber at the bottom. Usually they're a specific color. Oftentimes they're yellow, and that can help to identify a fall risk. And we want to stay with the patient in the shower because that is a high-risk fall time with the water and also slippery. And sometimes people put a towel down because they say it's less likely to fall, but they can trip over that. So we just want to keep that in mind. Then we have TED stockings. So these are gradual compressions that promote venous return and decrease the risk of a VTE, but they must be the proper size with no folds or wrinkles, and all wounds must be covered with dressings. We also want to make sure if patients have TED stockings on that they have the socks with the grippy over them because TED stockings are very slippery. Okay, so let's talk fire safety. So we can remember fire safety as RACE. So first we're going to rescue the patient, then we're going to activate the alarm, we're going to contain the fire, and we're going to extinguish the fire. If it's small, we can remember how we extinguish a fire using the acronym PASS. So we're going to pull on the pin, aim at the base of the fire, and we're going to sweep from side to side. And that is our PASS. That is how we use a fire extinguisher. So next on our NCLEX review, let's talk about seizure precautions. So the first thing, what we want to do when a patient is on seizure precautions is we want to make sure that the side rails are raised on the bed. This says child, but it's child or an adult when they're sleeping or resting. And we want to make sure that there's pads on those side rails because if they do have a seizure in the bed, we don't want them to hit off the side rails and injure themselves. We want to make sure there's a waterproof mattress or pad on the bed because oftentimes these patients can be incontinent when they have a seizure. We want to instruct the patient, this is child but or adult, to wear a medical identification bracelet. We want to instruct them to take precautions during potentially dangerous or hazardous activities. So this says child but also adults. This is for, let's see, I'm going to put over here for child and adult. So things like driving, they should be careful, or riding a bike or anything where if they had a seizure could be potentially dangerous for them. So they should have some precautions. Some people with seizure disorders don't drive cars. They have people drive them because it's just too dangerous. We want to make sure, so for example, things like swimming, always make sure you swim with a companion because if you have a seizure in the water, you want to know that you can get saved. You wearing helmets and padding, and alert caregivers for any special precautions that are needed. So what are our nursing interventions? These are the really key stuff. So when we have a patient that's on seizure precautions and they're in the hospital, we always want to ensure a patent airway, right? Airway, breathing, circulation, ABCs. That is one of the key things to know for NCLEX. Part of ensuring a patent airway is having suction equipment and oxygen available. So this means at the bedside. So if your patient is on seizure precautions, you should be having this equipment at the bedside. They're not going to ask you a trick question like a patient on an inpatient unit, because like on an inpatient psych unit, we wouldn't have the section available because it's a ligature risk. But obviously NCLEX is like an NCLEX world. So regardless of what unit it is on NCLEX, you want to make sure you have the section equipment and oxygen at the bedside. You also want to make sure that you time the seizure episode. That's going to be important for your notes and for passing on to the team when they come and the physician. You want to be able to tell them how long the patient had a seizure for, because this is going to show their outcomes. What is the potential of having some brain damage or things like that? The time is really important. If the patient is standing or sitting, ease them to the floor and place them in a side lying position. This is very important. And this is because if they vomit, we want them to be able to not aspirate on the vomit. We can place a pillow or folded blanket on our hands under their head or put their head in our lap. This is because if their head is rocking back and forth, we don't want it smashing off the floor. We want to loosen restrictive clothing, remove eyeglasses, clear the area of any hazardous object, allow the seizure to proceed and end without interference. You don't want to try to hold them down or something while they're having the seizure. Again, if the vomit occurs, turn the patient to one side. Do not restrain the patient or place anything in their mouth. Prepare to administer meds as prescribed. This is most likely going to be IV because patients cannot swallow. If they don't have access, it may be IM. And it's going to usually be a benzodiazepine, probably Ativan, but could be something else. We want to remain with the patient till they fully recover, observe for incontinence, and document. And again, this is where we're going to put that time, how long the seizure lasted. So let's talk about patients ambulating with a cane and visually impaired patients. So when we're talking about NCLEX, we want to make sure that patients are holding the cane on the unaffected side, so that the cane and the weaker leg can work together on each step. We don't want the cane on the same side as the weak leg because that could cause the patient to fall over to that side. So what we want is the cane to be on the opposite side so they can lean on that opposite side while they're putting some effort with that weaker leg, and it will create a stability versus all of the weight being on one side of the body. They move the cane, it should be moved at the same time as the unaffected leg. So as they're taking steps forward, when they are stepping with the unaffected leg, that's when they're moving the cane. And that's because they're going to have all their weight on that unaffected leg. It's going to be a lot more stable. And then we also want to remember that when going up and down stairs, the cane always moves before the weaker leg. And that's again because we want that cane to be moved. It's off the ground. There's less stability when they're on the unaffected side. All right, so let's talk about visually impaired patients. So we want to make sure that when we're caring for visually impaired patients, it sounds counterintuitive. It sounds like it would be obvious, but use a normal tone of voice. Oftentimes when people aren't understanding us, and if it's because it's a visual impairment or some other impairment, we naturally tend to raise our voice, but we don't want to do that with patients with a visual impairment because they can hear us just fine. We want to alert the client when you're approaching. You should do this for all clients. This is a part of trauma-informed care. Knock before you enter the room, explain who you are, what you're going to do. All of that's really important. You want to orient the client to the environment. Let them know where things are. If they have a meal tray, you can do things like use clock placement for the food on the tray. So, at 1 o'clock you have your orange juice. At 3 o'clock there's an apple. You can do it like that. Have the client remain one step behind you when ambulating so they can follow you, and instruct the patient to use a cane. So this is the cane that people with visual impairments use, where they sweep it in front of them. They'll hold it in their dominant hand and they'll use a sweeping motion in the area of which they are stepping. So let's talk about diets. And this is in the safe environment section of my NCLEX review packet, because if a patient is on a specific diet, it is a safety issue that we keep them on that specific diet. And this could be something like if they're on a protein restriction because they have high ammonia levels, us giving them protein is going to make that worse. So it is a safety issue. So we need to be understanding of what is considered a carb, a fat, a protein, clear liquid, full fluid, Mechanical soft, we have to understand all of these things so we can follow those policies. So when we talk about carbohydrates, like we might have patients on a low carb diet or a carb counting diet if they're diabetic. So it's important to know that things like milk do have carbs. That's because of the sugars in it. Grains, fruits, vegetables, all of those are carbs. Fats are going to be things like beef, pork, lamb, dark chicken, dairy, lard. Protein is our lean meats, our seafoods, beans, soy, eggs, nuts, seeds. Clear liquids can be water, bouillon, clear broth, carbonated beverages, gelatin, hard candy, lemonade, or an ice pop, really anything that's a see-through liquid. A full fluid is going to be things like plain ice cream, sherbet, milk, pudding, custard, fruit juice, so things that are liquidy but aren't necessarily see-through. And a mechanical soft is going to be things like pureed, mashed, ground, chopped. We want to avoid things like nuts, fruits, vegetables, and tough meats. Parental medication administration. So the first thing we're going to talk about is an intradermal injection. So this is an injection on the inner, it can be given on the inner forearm, the chest, or the back. It is given at a 10 to 15 degree angle, and it's usually a very small amount of fluid injected, 0.1 to 0.2 milliliters. This would be things like a TB test that you get on your forearm. That would be something that's an intradermal. It's just right under the skin. It makes a little bubble when you do it, and that's called an intradermal. Then we have something called a subcutaneous injection. So we can do these in places like the outer upper arm, the anterior thigh, and the abdomen. These are going to be a 45 to 90 degree angle, and 0.5 to 1 milliliter is injected, and usually no more than 1 milliliter will be injected. So these are things like our insulins. There are some other medications that are given subcutaneously as well. Heparin, buprenorphine can be given like this as well. Yes, that's a subcutaneous injection. So then we have an intramuscular injection. So this is going to be given at a 90 degree angle. It can be given in the gluteus, the thigh, or the deltoid. It can be given up to 3 milliliters in the deltoid, but no more than 2 mLs in the deltoid. So up to 3 milliliters when it's in other places like the thigh and the gluteus, but in the deltoid, it's no more than 2. No more than 2. These are things like our flu shots. Most of the vaccines will be given this way. Then we have intravenous. And when we're giving intravenous medications, we want to make sure to use aseptic technique, monitor the IV site for redness, warmth, and swelling. And different complications that can occur are things like infiltration, where the medication is seeping out of the vein into surrounding tissue, or phlebitis, which is inflammation of the vein. All right, now we're going to talk about the central catheter. So this is for long-term IV use of antibiotics, chemotherapy, and TPN. It can be peripheral PICC, a vascular access port like an implantable port, or a tunneled central venous catheter. So our nursing interventions are going to include, if we're placing a central line, we want to change the tubing or remove the line, place the patient in Trendelenburg, and have the patient perform the Valsalva maneuver. So this is when we're placing it. This is how we would do it. Now, when we have a patient with a central catheter, we're monitoring for infection, embolism, and occlusion. We're using sterile dressing changes. And if an air embolism is suspected, place the patient in Trendelenburg and left side laying. So now let's talk about a tracheostomy. So this is an opening directly into the trachea. A tube is inserted and attached to a mechanical vent or other oxygen device. Then the cuff is inflated. If used for patients at risk of aspiration, unconscious or mechanically vented patients, it is uncomfortable for patients who are awake because it's difficult to swallow or talk. And that's if it's inflated. A deflated cuff is used when a patient is improving and are not at risk for aspiration. So our nursing interventions include assessing respirations, bilateral breath sounds, blood gases, pulse ox, and signs of bleeding. We can put the patient in semi or high Fowler's position. We can suction as needed, pre-oxygenate with 100% oxygen, insert the suction tube without suction turned on, intermittent suction in circular motions during withdrawal, suction no more than 10 seconds, and wait 1 to 2 minutes before suctioning again. And if the client is allowed to eat, sit them up. If the cuff is inflated, if the tube isn't capped, up until 1 hour after meals. So we inflate the cuff if the tube isn't capped, and we can leave it that way up until 1 hour after the meals. And we never insert a plug or cap into the tracheostomy tube until the cuff is deflated and the inner cannula is removed. Blood transfusion administration. So when blood is received, we need to verify the product with the type and cross match with 2 patient identifiers. So type and cross match. 2 patient identifiers with another nurse. Only infuse blood 1 unit at a time, and also blood must be administered within 20 minutes. Assess patient, take a set of vitals, and teach the patient signs and symptoms of a transfusion reaction. Use a wide tubing primed with normal saline, clamp normal saline side. Spike the blood product and leave the clamp on the side of the blood open. Begin the transfusion slowly under close supervision. This is key, close supervision for 15 minutes. We're going to monitor for a reaction. So we're looking for a hemolytic, allergic, or febrile symptoms. Chest pain, tightness, fever, back pain, anxiety, tachycardia, hypotension. If a reaction occurs, we stop the transfusion, keep the line open with normal saline, and notify the healthcare provider and the blood bank. These are the questions you will most likely be asked on NCLEX. They want to know that you stay with the patient for 15 minutes, that if a reaction occurs, you stop it, that you keep the line in with normal saline. If no reaction occurs, you can increase the rate, take another set of vitals 15 minutes later, also take a set of vitals at the end of the transfusion, and once the transfusion is done, open the normal saline clamp to flush all of the blood out of the tubing. Inserting a Foley. So to do this, you're going to gather equipment and explain the procedure to the patient. It is a little invasive, so we want to explain it before we do it. Again, that is that trauma-informed care. Assist the patient into a supine position with legs spread and feet together. Open the catheter kit, prepare the sterile field, apply sterile gloves, and check the balloon for patency. Generously coat the distal portion 2 to 5 centimeters of the catheter with lubricant and apply a sterile drape. If they're a female, separate the labia using a non-dominant hand. If male, hold the genitalia with the non-dominant hand. Maintain hand position until preparing to inflate the balloon. Using a dominant hand cleanser, cleanse the inner to outer area. So we make sure we go anterior to posterior with 1 swipe per swab. We want to pick up the catheter with our gloved and sterile dominant hand, hold the end loosely, and coil in the palm of the dominant hand. In a male, we want to lift the genitalia to a position perpendicular to the patient's body and apply a light outward traction. Identify the urinary meatiness and gently insert until 1 to 2 inches beyond where the urine is noted. We want to inflate the balloon and gently pull the catheter until the inflated balloon is snug against the bladder neck. Connect the catheter to a drainage system and secure it to the abdomen or the thigh without tension or on the tubing. Place drainage bag below the level of the bladder. Evaluate the amount, color, odor, and quality of the urine, and document the size and Foley and the amount of cc's inserted into the balloon. So the next thing we're going to talk about is delegation. So when we talk about this, you're going to have certified nursing assistants. They can do ADLs, toileting, monitoring, patient safety, and assist with walking and linen change. LPNs are directly responsible for nursing intervention but not assessment. They cannot give any IV meds. When we assign tasks, we want to choose the most critical patient to assign to the nurse, such as the client who's recently returned from brain surgery. Patients who are being discharged need to have a final assessment done by the RN. So anyone discharged is with the RN, and anyone who is critical is with the RN, or the most critical patient. The LPN can insert urinary catheters, feeding tubes, apply restraints, discontinue drains and sutures. Do not delegate what you eat. So anything that you have to evaluate, assess, or teach has to go to the RN. So when we talk about advanced directives, a do not resuscitate or DNR order is when the client or their legal guardian must provide informed consent for the DNR status. The nursing intervention is to know the advanced directives of all patients and have your practice follow them. If there is no DNR order, then the healthcare provider must make every attempt to resuscitate the patient. Lastly, for this section, let's talk about carbon monoxide poisoning. So just so you guys know the levels for NCLEX, 1 to 10% is normal. When we get to an 11 to 20% carbon monoxide poisoning, you're going to see headache, flushing, decreased vision, decreased cerebral function, and slight breathlessness. 21 to 40% is a headache, nausea, vomiting, drowsy, vertigo, confusion, pale skin, hypotension, tachycardia. 41 to 60 is coma or seizures, and 61 to 80% is death. Let's talk emergency medicine for NCLEX. So the first thing is CPR. So when we're talking CPR, we want to remember compressions first, then airway, then breathing. So we want to determine the unconsciousness, then we're going to check the carotid pulse. We're going to start chest compressions if there is no pulse. Then we're going to open the airway using the head tilt chin lift, and we're going to check breathing and deliver. When we're talking about foreign body aspiration, we're going to not do a blind finger sweep. So if you ever see that as an answer, that is not the answer. The risk is that we're going to push that object down if we stick our finger in their mouth. If it's an adult, we stand behind the patient, place the arms around the patient's waist to make a fist, place the thumb side of the fist above the belly button, and with a quick in and up thrust, we're going to do, this is the Heimlich maneuver. For an infant, we place the patient over an arm or on the lap with the head lower than the trunk. 5 back slaps with the heel of the hand in between the shoulder blades. Turn the infant and perform 5 chest thrusts. Check for the foreign object, and you're only removing the foreign object if it's visible. We have to remember that when patients have an impaled object, so something that is stabbed into them, we do not manipulate or remove it. We want to make sure to stabilize it. That's because when we remove it, they're just going to start bleeding everywhere. When we talk about triaging a patient in a disaster, what is important to remember is the color coding system. So for red, these are going to be our patients or people who have a life-threatening injury that a patient may survive if treated within an hour. So things like cardiac arrest, respiratory distress, amputations, acute neurodefects. We could save them in an hour. Then we're going to talk about the yellow. So this is patients that can wait 30 minutes to 2 hours without loss of life or limb. So these are things like open fractures or large wounds. When we identify people as green, we call these the walking wounded. They can wait 2 hours for treatment. So these are things like closed fractures, minor lacerations, and sprains. And when we identify somebody as black, this is the unlikely to survive group. So these are going to be people that are unresponsive, have spinal cord injuries, 2nd and 3rd degree burns over 60% of their body. And then let's also remember angioedema. So this is rapid swelling of the lips, tongue, throat, face, and larynx, and can result in airway obstruction or death. This is usually an allergic reaction. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.